Then there's Zima that has come up with Smile. So Smile has a lot of competitors. So Smile is going to get even better and better and better. Okay? So let's talk about the things that would worry you. What I said, worry me is like you, okay? You, when you are talking to your patient, if they come to you and say, what should I be worried about? So you should be worried about infection, okay? Infection before surgery. Infection after surgery. So before surgery, I'd be really worried about viral infection if I'm doing LASIK, because the UV light, which is very close to eczema, can aggravate past herpetic infections. So I'd be very particular about the viral infections. And in Kathmandu, you are very, very prone to have infections after surgery because it's so dusty. And you know your patients, they're so adamant and so stubborn, they don't listen to you. Okay? So inflammation, this is something very, very serious. Like you have to really rule about your inflammation, anything autoimmune like rheumatoid arthritis, thyroiditis. You have to think about inflammation that's going on in your body. You don't have to send, because you people are so smart enough, you don't have to send your patient to any surgeon to rule out inflammation. You can just ask, you can say, do you have arthritis? Do you have backache or anything? And if you think that the patient is not fit for surgery, you can always tell him, don't go to the surgeon, that's it. You know, there's no point taking unnecessary risk over here. Swelling, this is something you have to tell your patient. The younger you are, the lesser swelling that you get. So the visual recovery is faster with the younger patients. After 18, 19, 20, 21, the swelling goes out faster. The swelling goes out because of the endothelial cells. So the younger the patient, they have more endothelial cells. So the older you are, at 45, your swelling is going to last for longer. And the cornea doesn't have any blood vessels, so it's going to be even longer, unlike the rest of the body. Okay? Scarring, you can get a lot of scarring in the cornea. What we are worried, what you should be asking about is any keloids, you know. Do you have any scars that has been like, you know, keloid is something like hypertrophic scars. Those people are the ones, they have a tendency, you can, it's not necessary, but there's a tendency that you can have a lot of scarring there. Dryness, you have to tell your patient that there will be dryness after surgery, whether you do LASIK or whether you do SMILE. There will be dryness, but it's temporary, it's going to get better. In SMILE, the recovery is very, very fast, but in LASIK, the recovery is slower. It takes a longer time, and sometimes even years, and sometimes even a lifetime in LASIK. So, and my biggest fear again is ectasia. I think this is the biggest fear for everyone, keratoconus. Ectasia after surgery. This has been a big topic. Now, SMILE has been a big boon in refractive surgery because the cornea is so much stronger compared to LASIK. Much, much stronger. But then, you have to really understand one thing is that when you're sending your patient for refractive surgery, there are certain things that you want to see, you want to find out that a surgeon has. The scans, the number of scans that a surgeon has, and how is the surgeon ruling out ectasia. It is very, very easy to see ectasia. You put a patient on a corneal topographer, the scanner will tell you the patient has ectasia, keratoconus saw. What we are really worried about is the hidden keratoconus, the keratoconus that is hiding. The form thrust or subclinical keratoconus is something that you want to find out. Those are the corneas you don't want to touch. Okay? So besides all that, I will get back to ectasia again and the scan reading. So I do my surgeries after 18, but not necessary. In the sense, in Nepal, you know, most of the people over here, like 25% of my patients who come to me are joining the British Army, or they're going into the French Army or somewhere. And that's the time, that's 18 to 20. If they have -1, -2, -3, I'm okay with that. And we want to see the history of the prescription. If it is stable, yes, I don't mind doing it. If the scans are good, I don't mind doing it. But after 4, 5, 6, I would say, let's wait. Then I would go to 20. And if it's minus, more than minus, probably I would wait till 22. Okay? And depending on the history of the prescription, the scans and everything. And it's also very important to see the stability of cylindrical power. You know, the cylindrical power changing its axis, increasing or decreasing, whatever. But for you optoms, you're very, very good with your refraction. You can easily tell just like that. There's something going on wrong over here, unlike the surgeons. Because we don't know. We don't even know how to do retinoscopy. I bet 90% of us surgeons, we don't know what a scissor reflex looks like. I'm sure. But for you all, it's so easy. You can just do a retinoscope and then you say, yes, there's a scissor reflex, there's something going on. It might not be there for all the patients, but it's so easy for you all to diagnose because you all can tell the history of the prescription, whether it has been unstable, whether the cylinder has been changing, something like that. You know, you can just guess, oh, there's something going on with this patient. It's the intuition that has to come from inside. And you want to rule out all the ocular diseases like glaucoma, retina, retinal breaks, retinal holes. You want to treat everything before. You want to treat squint, you want to treat ptosis, whatever, you know, you want to make sure everything is finished. And then only you want to jump into refractive surgery. You want to do dry eye workup, you want to see if there's, you know, corneal sensation you want to see because you don't land up with extra dryness or you want to rule out any herpetic disease in the past. Let me have a look at these scans. So by the way, these scans, this presentation was made by Dr. Purushottam, okay? So I really have to see. So he's my expert. In Tilganga, all my patients are worked up by Yashashvi, Rajashvi, Purushottam, Sahashvi. We have a team. So I only do the surgery. I do the refraction at the end, before the surgery, and they work them up. So these guys are experts, you know? So they teach me so many things. So looking at the first scan over here with the smile, that is a normal scan. This is just a corneal topograph, Atlas Zeiss, okay? So if you look at that over here, where do I point? This side or this side? If you, which one do you want me to point? I need to point a little bit. If you look at the first scan, this is a normal pattern, which looks like a normal number 8, okay? You want me to do that? This is a number 8 pattern over here. This is a normal pattern, but this necessarily does not mean this is a normal scan for refractive surgery. This is a perfect scan, you know. This is inferior steepening here, looks like a pellucid over there, things like that. These are all abnormal scans. This is what we want your scan to look like at a corneal topograph. If you're looking for this, 95% of your patients will be cancelled. Nobody gets this scan. So it is very, very important that you should understand that your surgeon has gone through a training with the scanning and everything. So this is a normal scan. You want to see, this is a pentacam. What we are looking for is the front elevation over here, the back elevation over here. This is a normal one. This is the front elevation, which is quite steep here, and the back elevation. These are the things. The back elevation is very, very important. Sometimes with a very normal corneal topograph, you can have a back elevation. Even if your front elevation is very steep, the back elevation is something we really want. The back elevation is very important. You want to make sure the back elevation is within normal range. You don't want to touch any cornea that has a back elevation. The back surface of the cornea has to be very strong. So, and then what we do is a corneal thickness, okay? The corneal thickness is very important, the pachymetry. Let me give you an example. Everybody knows Bruce Lee, yeah? Bruce Lee is thin, but very strong. What I'm trying to tell you is even a thin cornea can be very strong to do refractive surgery. It is not necessary that a thin cornea is not strong. But You can have a fat cornea, thick cornea, it can still be very weak. If your